All right, so good evening and welcome to tonight's webinar. I am Wendy Golden. I'm an endodontist and medical affairs for Sohn Endo. So tonight we are going to learn about the clinical and technological changes in endodontics over the past several decades and describe the rationale for incorporating gentle wave into a modern practice. We're going to look at the differences between cases that were treated with and without gentle wave and discuss the clinical considerations that help guide us to use certain technology and when conventional treatment may be more appropriate. We'll also look at a step-by-step clinical protocol for using the gentle wave system, including access, instrumentation, activation, and obturation, and practical tips along the way. Tonight, we will offer two CEs for this event. One, you must be registered for the event. Your attendance is going to be recorded via Zoom. Please make sure your full name is under your profile, and if it's not, will you include it in the chat and we'll make sure that we get you. We're going to send out a survey, and we ask that you complete this and then send us back to us. Once we get that back, we will send you your CE certificate via email. If you have any questions along the way, please reach out to myself or education@sonendo.com. Tonight's webinar, like all of ours, we want it to be interactive. Your questions are deeply encouraged. During the presentation, which will last about an hour, when questions come up, you can just place them in the chat box. We're going to leave 20 to 30 minutes afterwards. You're welcome to come off mute, come off camera, and ask Dr. Peak any questions you have along the way. But before we get started, we have exciting news again. Flow Logic is here. These are 4 files designed to select to support the refined role of the file when using gentle wave. It allows you to establish or restore a flow path so the system can completely clean the root canal. We have very good pricing for our gentle wave users. We are also going to be offering a complimentary sample. You're going to see that in the survey. So if you simply click Flow Logic sample request box on the CE survey, you're going to, we will make sure to send you a sample pack. Tonight is my pleasure to introduce you to a friend and colleague, Dr. Peak. Dr. Peak attended LSU endodontic school. He's a board-certified endodontist. Dr. Peak practices at Eastern Iowa Endodontics. So, Dr. Peak, I'm going to stop sharing and turn it over to you.
So again, Wendy, thank you very much for the introduction. My name is Derek Peak. I live and practice in Cedar Rapids, Iowa, and I run my own practice. And so tonight is kind of for me to share my story of kind of how I went from no gentle wave to gentle wave in my practice. So I know there's 2 groups of people out there. There's a lot of people who have the gentle wave, which is great and awesome. So hopefully this is just some fire in your tank to keep doing what you're doing and know you made the right decision and that this is great for your patients. And for those of you out there that maybe are on the fence, kind of like I was, and are still questioning the technology, hopefully this is just a little bit more of an encouragement to you to ask more questions and keep growing and seeing if this is the technology that can kind of work in your practice. So the benefit of me is I get to run my own practice, plus I get to play around with my logo. So we try to do a fun logo every time of the year for our Halloween and Christmas and that time of the year. So we put a Santa hat on our logo down and we do fun stuff like that. So yes, I am here for Sonendo to talk about the gentle wave. I just kind of put this up there to just say this is my 13th time doing it. I enjoy being on this side of the camera and just sharing my experiences, mainly just to make relationships with you out there and just to share what I've learned, because I've had a lot of people share with me in my career, and I think it's very beneficial for all of us just to meet in this forum and just talk about what we know and what we can do and how we can help our patients. But before I get started, I always make it a point to talk about my staff. because I don't think I would be able to do what I do or help the people I can help without these ladies. And so we all have a staff out there, and they work for us, but really give back to them. I've really the last couple years have been kind of doing more nice things, and we do more events, and man, it really just helps the flow in the office. So yeah, we're going to spend time talking about teeth, but really, for those of you out there paying attention, just thank your staff. Make it a point to thank your staff this week. Tell them you appreciate them and that they do a great job, because it really does go a long way. And in an office, when it's running smoothly and everything, man, they're the lifeblood of what we do and how we get to do it. So that's my little shameless plug for them. I know Wendy went over these learning objectives. I'm not going to read them again. I think you guys all read them. If you want to skim them, you can. But basically, I'm going to talk about some background with endo. We're going to talk about kind of how I make decisions of when I use GentleWave, when I don't use GentleWave. And then I'll just kind of go through a step-by-step process of how I treat teeth in my practice. So a little bit about me. This is not long. This is super short. Out of high school, I went and played football at SMU in Dallas, Texas. Josh McCown was my quarterback there. That was great. But then I went to a small D3 school in Chicago and ran track and played football there. Out of college, I went back to my high school in Oklahoma City, and I was a seventh grade science teacher and coach. So ask me questions. I enjoy questions. I enjoy, answering the ideas and concerns that you guys have. So please ask and ask away. After teaching for 4 years, I got into OU in Oklahoma, and then I got right into LSU in New Orleans for my endo residency. And then directly after that, I moved to Cedar Rapids, Iowa. I actually started with my dad in his practice, but as luck would have it, I got to start my own practice a couple months later, and so I started Eastern Iowa Endodontics. And in the time right after residency and starting my practice, yes, I still was going through the board certification process, and I was able to complete that just 2 years later in June 2017. So shameless plug there. I think board certification is important for those of you that are on the track or getting ready to pursue it. Keep going; it's worth it. So now I'm looking at that date, 2017. So about a year, I'm going to have to do my 10-year re-up on that. So it's worth it. So stick with it. Also, I got to give shout out to the people that kind of made me who I am. I think my dad is important. He was an endodontist for 45 years. James Rohn in Oklahoma City. We all know him because of Balance Force. I know you guys all said it. There's another trivia for the board thing. I did a lot of research with him at OU. Really smart guy. Really kind of fed me a lot of endo stuff in undergrad and really kind of helped in my residency. Obviously, my two program directors at LSU, Dr. Emo and Dr. Sabi, they were really good at pimping us and asking us all the questions, but also thinking and helping people at the same time. And then the late John McSpadden, I got to pick his brain about files. And, of course, we read the textbook in endo about all the qualities of files. And, he really started using them in microscopes in the 80s. But he was pretty instrumental in kind of my thought process through things too. This is my office. This is not what Iowa looks like right now. We have a lot of snow, but the benefit of my office is we have a garage in the back, so I get to park my car in the garage back here, which is really nice. My dad built the building. Currently, there's 10 ops. It's just me. I'm looking for an associate, but things are great. I enjoy it. So those of you that are looking into buying a practice or building your own building, I kind of have some advice. Make sure that CBCT is right off the door that goes from the waiting room. So you take that right away. I know we just came out with the new protocols for CBCT, and I think I read that yesterday, and I'm pretty certain it said small field of view on almost all of them. So I think that's an important thing to have in your practice. Also, big rooms with windows. Don't make it cramped. Make it bigger than what you think you need. So you can get your microscope on the wall and lots of room for everything that you need to wheel in and take out. Plus, it's just easier to clean. And the windows that are actually the best are windows that face north, because the sun isn't beating you down all day. You don't get the morning sun, you don't get the evening sun. You get the perfect sun all day. So big rooms, windows facing north. If you do that, you're going to have a great practice. I show this slide, not that I'm an expert or that I know everything, but I've put in my time. I've put in about 10 years, and this is always kind of a fun slide for me to show is that I'm still smiling. I still kind of have my crooked nose. I'm in the same op. I got the same microscope. I'm still wearing black scrubs. I'm still doing the same thing, and I'm still putting in the work, and I still really love endo. So, we all can kind of go back and look at old pictures, but you always want to make sure you're smiling and you're exactly where you want to be. And I still feel like I'm exactly where I need to be. I enjoy this profession. I enjoy helping people. But I got a little bit more gray hairs in the mix, which I think is just fine. And also just a little bit of perspective. The young guy on the right, that was probably about a year and a half in. I'd maybe done like, I don't know, less than 2,000 cases. And I just looked today and I'm at 16,263 cases. So right now, 10 years in, with a lot of data and everything that I'm doing in my practice, I average about 1,600 cases a year. I think that's a really good year. And that's kind of our number that we're trying to strive to be. 400 a quarter is really kind of something that we go by. And that's just me. I know it's different for everybody else. But I would just encourage you to work at your own pace. And, numbers are just numbers. And I'm just trying to be transparent and just kind of share my practice and share kind of how things work for us. So first objective, just kind of how did I go from doing traditional root canals to incorporating gentle wave into my practice? How did I make that decision? I realize I'm not a normal individual because I grew up in an endodontic office. I grew up going to my dad's office and smelling the developer and smelling the fixture of the radiographs and going in the dark room and, my dad mixing the Roth sealer and making sure it goes up, all the things. So all the smells and everything. So inherently, I've kind of seen endo change my whole life. What I saw my dad do as a kid is not what I do in my ops on a daily basis. And so I think all that plays into account of what I've seen, where I think endo is going, and what I want endo to do within my career. So I was very fortunate to have a dad in the profession, and we got to work. He retired after 45 years. So just some math on him. He graduated college at 20. You didn't have to graduate back then. He got his requirements done and got into dental school at 20. Graduated dental school at 24, endo school at 26, and practiced for 45 years. I was thankful I got to spend the last 10 years with him, which was great. And so 24 when he graduated dental school, and we got to spend 10 years practicing together side by side, old versus new. And he learned a little bit from me, I learned a little bit from him, and back and forth it went. But it wasn't just the treating patients or the asking advice on cases or what do you think about this diagnosis or all these things. It was, hey, where's this profession going? Like, what's endo going to look like in the next 30 years? Or Dad, you practiced 45 years, forever. How do I extend my career? How do I make sure that, I don't have hand problems, I don't have neck problems, or my eyes are good, or all these things. So, we didn't just talk about endo. We talked about everything outside of endo and business and how do we make decisions and all that stuff. And so, this talk is more geared to how we talked about doing root canals and how we kind of took his classical lit and, everything I was learning and new files and kind of where endo or where we think endo is going. And the best way I know how to describe that is just to show you pictures. That is very much how my dad practiced dentistry when he started. no masks, no rubber dams, or no, yes, rubber dams, no rubber gloves, um, a spit bowl to the side. I mean, that's very much what dentistry was in the 70s. He only wore rubber gloves when they did surgeries. That was it. Everything else was just like you see. And I think we can all appreciate, having gone through COVID, it's very different in our world. And there's definitely different protocols that we have to follow, which I think are very good to have. Also, I did get to experience this. This is a quick fix dip tank for those of us that had to take uh, films during dental school and wanted to know whether we got our working length right. We could put it in there and we could dip it real quick in about a minute and look and see if we got the right working length. For those of you that have no idea what this is, good for you. You know, you just had digital, and we can press a button as many times as we want to until we get what we want. But, you know, learning the old way and not having immediate gratification really kind of helps you go, man, I need to get this working length right because I don't want to go wait in line, have to dip this and count to 30 four more times and make sure I got it and all these things are the right angulation. So I think there is some merit to kind of the way things used to be done. Also, you know, I can walk into my dad's basement and he has thousands of these little file boxes of all the films that he had of all the cases. And, you know, sometimes we'll go down and we'll just pull a couple out and, you know, see how they worked. And they you know, pretty good job. But, you know, digital and with the cloud, I can probably put all my cases on my thumb drive right there. So, you know, you can already kind of see how things are changing. And, you know, with my dad, I was still amazed towards the end of his career. He'd be getting working length and I'd hear it buzz and I'd come in here and I'd check the x-ray and he could pretty much get working length every time pretty much right on the apex without an apex locator. You know, I'm pretty much bound to my locator because it makes it that much easier and that much quicker. If I had to kind of do it by feel, I think I need another 10, 20,000 cases in me before my fingers start feeling it. But I think I'm getting there. But it just goes to show is that there is some talent, there is some tactile feedback to what we do and to really kind of focus on that and that it does play a part in it. But you know, the big thing in his career was those were all the files that they had. They just had hand files, no rotary, no nothing. And you had to do it all by hand. And then, if you know your history, Tulsa Dental Supply Company, now Dent Supply, all those things started in Tulsa, Oklahoma, was just about a 2 hour drive north of Oklahoma City, where I was born and where my dad practiced. And this guy walks into my dad's office and goes, "Hey, Tom, I think we're gonna make this rotary file company in Tulsa. Do you want any part of it up here, all this stuff?" And my dad, like every other endodontist at the time, was, you know, what I'm doing right now is just fine. It's predictable. I have my hand files. We're making good money. I can do all that, you know. So I kind of got to learn the lesson from my dad of don't get stuck in your box. There's going to be new things that come out and you need to look at them and just don't think you know everything and that you know you might miss something. You might miss the opportunity to invest in this or learn something new or something else is out there. You know, I don't think my dad regrets not going in with Bill Johnson, but it's sure fun to kind of think about or talk about, you know, especially when you see all the files that are coming out on the market now and all the things. And so I think files are great. I love trying new files. Um, uh, Shameless plug. I did get to try the new in Sonendo files, and I think they're very good. I enjoy them. I think they're going to work into my protocol very easily because they do what they say they're supposed to do. They're very minimally invasive. They help you get a clean glide path all the way down to the apex, and that's pretty much all you need nowadays with GentleWave. And so, for those of you that haven't tried them, I would encourage you to try them. I'm a fan. I think I'll probably be signing up for more of those. I know they're early in the career, so you know they're probably going to go quick. But so far, you get two thumbs up for me for the Sonendo files. But back to kind of this logical thought of what I'm trying to get to is how did I get from just hand files to rotary files to now GentleWave is, you know, all the things my dad would talk about and he and I would talk about, you know, this was kind of the quote that I heard him say that just kind of stuck out. After 45 years of cutting holes in teeth, putting files down teeth, putting sealer down teeth, putting gutta percha down teeth, he kind of summarized and said, Derek, if you can do endo without having to put anything down the canals, you should probably do that. And it just kind of planted the seed. I was like, oh, that's a lot of experience. That's a lot of cases for somebody to go, you know what? Maybe what I was doing for 45 years wasn't the best. Maybe there's something new out there that's better. And so that just started, playing over in my head. Also now and then to keep kind of hammering this home. We don't do that anymore. I pretty much inject my sealer. This is my favorite story. Whenever I would go see my dad, hey Derek, how was your day? And he's working on patients, and he puts the plugger back in the open flame behind him, and he pulls it out, and it's red hot, and he shoves it in the patient's mouth, and I see all this steam, and I'm going, well, one, my dad's pretty cool. He gets to play with fire all day. Number two, what is he doing in the patient? I didn't get it. I was a kid. I had no idea. I still am a little bit jealous that I don't get to play fire with fire in my practice. We have to use touch and heats, but now we have cordless ones and you can pretty much pick your own color. So to kind of summarize everything, if you look at how my dad started his career versus how he ended his career, there was really only two things that didn't change. Um, I mean, Apex locators changed. He just didn't adopt that. But really, the two things that were the most the same through the whole time was using rubber dams and putting bleach in teeth. Everything else in his career changed. The sealers changed, the files changed. They were doing 2 and 3 appointment. Now it was 1 appointment. Everything changed. And so once I started putting this into a spreadsheet and really kind of thinking about it, am I naive to think that what I'm doing right now is going to be exactly what I'm going to do in 20 years? No, I think everything that I'm going to do is going to change too. Right now in just my career, I've changed rotary files, I've changed the sealer, I've changed my obturation technique. System B, I guess you could say that changed too to touch a heat because you went from corded to cordless. But a lot of things I think are pretty set in stone. We're always going to have gloves. We're always going to use rubber dams. Digital's not going away. Everything's pretty much going to be 1 appointment, but I think there's some things that probably are going to change. I think at some point, digital and everything that we're going to have is going to be so good and so clear. All we're going to do is scan them, and we're going to get a printout on our computer of reference points that you should use, where all the decay is, the length of everything. You're going to be able to put all your file characteristics in there, and AI is going to just spit out a spreadsheet of what you're going to do. So that's going to take a lot of thinking away, and it's going to be good. I think there's going to be new innovations with GenoWave and how we irrigate the teeth, and we already got that point. So that's great there, but there's going to be something. I think I don't know. I have no idea who's working on this, but some of the guys that I talk to that use GenoWave, we go, man, it's so clean. There's got to be an easier way than sealer or gutta percha, or I know there's the new odon and obturation thing, but I think that's a point of things that are going to change, because what I'm trying to look at here is just looking at the things in my dad's career that didn't change. I also think are going to be the things in my career that aren't going to change. Gloves aren't changing, rubber dams aren't changing, and 1 appointment's not changing. You can't get any lower than 1, but I really kind of think everything can change. And so looking at all these things and figuring all this out, in my dad's career, the big kind of balloon or thing that came out was rotary instrumentation. All the new files. These are kind of all the files that I've kind of gone through in my career. And so, not to belabor the point, but I look at myself here, a little bit younger, no Dupuytren's contracture in my right hand yet. What is that guy, going to think or have to say to this guy? Because that guy's coming. Hopefully I don't look that bad, but I'm going to have some wrinkles, and thankfully, hopefully I have that much hair, but maybe I have a little bit of Dupuytren's contracture. And so, I'm just kind of thinking, I think the thing is irrigation protocols, and talking to my dad and making these pre-GenoWave decisions is that's what's going to change. Um, because I think all of us out there have cases like this. We do it. We know how to manage the curve. We have a nice dense fill. We find all the canals and we can look at ourselves and go, all right, good job for us. But unfortunately, I think a lot of us out there have a couple of those out there. And, I don't think we did anything wrong. Um, Sometimes the curve unseen is greater than the curve seen, and we're at the mercy of the files that we're using. And again, files are getting better, but that's a bad day. And so, when you have things like that, I still kind of go back to, my dad's quote, how do we do endo without having to put anything down the canal? And I think that's the beauty and the simplicity of GentleWave. And since I've had GentleWave, I've done a lot of experimenting with non-instrumenting endodontics, very minimal instrumenting endodontics, instrumenting things big, not instrumenting things at all. And it allows you that freedom to practice how you want. And so irrigation protocols, I really feel is going to be the thing that changes in my career, how we rinse and clean and irrigate the canals. It's not instrumenting anymore. I think we got all that figured out. I think that's practitioner dependent. But it's how do we clean and then how do we know that things are clean? And so when I'm evaluating all this, I'm obviously putting needle irrigation, which I don't think is the best anymore, towards lasers or the GentleWave. And so, you really kind of have to put yourself in that picture and you have to know, all right, which one of these things is going to be the thing? Which one is going to be the one I'm going to incorporate in my practice and make everything go by? And for lasers, I think they do a lot of great things and can offer a practice a lot of flexibility with a lot of things. But for me, in my practice, I pretty much do root canals. That's it. I don't do a lot of surgeries. I don't do a lot of retreatments. I do a lot of initial treatments. And that's about it. So I was looking for something that just fit that need that I needed. And when I was kind of evaluating both of the two, I felt like Sound Endo was the power tool that I wanted. Insert your Tim the Toolman Taylor grunt in there if you're, a 90s kid or 80s kid like me. But for me, it wasn't a multi-tool. It was a direct fix for what I felt was where endo was going, which was irrigation. And I do have to say this. I'm in no way knocking lasers. I do not know the ins and out of lasers. The best thing I can say about my perspective on things is that I'm for Sonendo. I'm not against lasers. This comes from my coach back in high school. Our rivals down the street were the Cyclones, and he was always good of saying, we are for us, we're not against them. So I just wanted you to hear me say, I'm not against lasers. I'm not against any of that technology. I'm just really for Sonendo and for GentleWave because of how my brain logically thinks it works into my protocol and how I treat endodontic cases and how I treat patients. Specifically, this is kind of something I read about diffraction. I think we can all look at this and go, yeah, light doesn't bend. It goes straight. It doesn't really go around corners. And I don't know about you, I hardly have any cases that are straight. There's always some curve somewhere. And I was just, how's the light going to do that versus I can pretty much yell around a corner and I know somebody's going to hear me. So the benefit of the GentleWave and the Sonendo and the sound and how it was using all of that to activate the fluid to get all into the nooks and crannies and dissolve the tissue of the entire root canal system made sense to me. And this was how I worked it out on my own. I think you all need to kind of figure out how it works or how you explain it in for yourself. But you know, to put things side by side, you got clean flow on the right. You just got to rest it on the top of the tooth. Nothing goes in the chamber, nothing goes down inside the tooth. Very beneficial for second molars, first molars, and any tooth in the arch. I've put it on any tooth and it works great. Versus my difficulty with the lasers was you still kind of had to put it down the canal. You had to get it within 1 to 5 millimeters of working length. Those aren't tiny. There you have to do some sort of instrumentation in there. So and then you got to withdraw it at 2 millimeters a second. Uh, I don't know that I've ever timed myself on how I would draw things out of a canal, but there is a certain technique to doing that. And so I kind of just did some simple math on my own. I knew I could use the gentle wave on every tooth because I can sit here and say I've used it on every tooth, maxillary, mandibular, front, back, every one of them. Um, with the lasers, I would kind of have to be chair side. I've done several of my gentle wave cases, and I got pictures here where I show where once I get to that, I just kind of step away. I let my staff take care of it, and then I take a break. We all work hard, and that was kind of the other puzzle piece is finding little breaks throughout the day because we all need it. But with the laser, I really felt like it was mandatory four-handed dentistry all the way through. Somebody had to be irrigate, somebody had to run the laser, all these things, and I was just kind of doing the math and going through things. And maybe on a regular molar, it's going to be anywhere from 5 to 9 minutes. Okay, so same, same, same. But the thing that wasn't the same is I had to be there versus Genowave, I didn't have to be there. So that's kind of how I worked through my process to get to where I am today. But I still was very much a skeptic for a long time, even though the guy on the left, me today had all that worked out of my brain. I still was, putting my hands on my hips because I wanted to know more. I just needed to know more. And at some point, you just got to jump and you got to take the leap and you got to have faith. And for me, how that kind of worked was, oh, I'll say this. For those of you that don't have a gentle wave or maybe might look at this and go, that is a lot of knowledge. I have no idea what's going on. Please just take a gentle wave 1.0 course. They will explain all this to you. It makes perfect sense. I could talk another hour about all four of these and how cool they are and what I've seen in my practice. But this is just a graphic. I know, probably 75% of you out there are like, yep, got it, Peak. Yep, we're good. A couple of you guys out there, go take a 1.0 course and really kind of dive into these and figure out how those work. But, again, my timeline, Skeptic the Scientist was, yeah, 2022. I was like, meh, 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 not, don't talk to me. But then Clean Flow came out, and then that met what my dad and I had been talking about. How do we do root canals without putting anything in the tooth? Aha, Clean Flow. All right, I'm listening. So I went and took a 1.0 class in Minneapolis, and it was great. Dr. Tolke, learned a lot from them up there. Still keep in contact with him. And then changed. That was it. I'm on board. But then the G4 came out, and my brain was already thinking, okay, the G4 is like a big iPad. They're going to be able to control and do all these different things with these fluids and control the concentrations and all these things. And I said, I don't care. I want the G4. So they're like, all right, we're going to go to another class. I went down to Louisiana, or not Louisiana, I went to Louisville, hung out with my buddy Mark Scott down there, learned more about it, and then, made the leap and jumped into the G4 even before there was Pro Control, or even before anybody had said anything about Pro Control. And now we all have Pro Control. We can control the concentration of the sodium hypochlorite that we put down in the teeth. And I wish I could tell that guy then how good of a decision it was, because I still was nervous. I still didn't know, how solid and how much I enjoyed it. But I wanted to get out and I wanted to talk. And this is my first class I gave in West Virginia, to the endo residents there. And then the reason why I put this on here, I went from not even stepping foot to the GenoWave booth at AAE to being speaker of the booth, or one of the kind of type, their little small talks, 15-minute talks a year later. So when I look back at all of this, basically I went from a fixed mindset to a growth mindset. And I don't know which arrow you're on. Maybe you're on the first arrow, maybe you're on the sixth arrow and you're almost there. Keep jumping to the next arrow because that's your desire to learn. You're going to keep learning more, you're going to keep doing more things. And so just jump to the next arrow. It may be a big jump, it may be a small jump, but when you look back on it, you're going to really kind of see how far you came and how much you learned. This is a book that I would encourage a lot of you to read. Think Again. Basically, Adam Grant talks about these four, or I'm going to start with these three, and I was every bit each one of those against gentle wave until I read this book. I was like, oh, preacher? Oh, yeah, I know I'm right. Traditional is good. My dad did it for 45 years. Oh, prosecutor? I can quote everything to you because I'm, you know, going to get board certified and I knew all of the literature stuff and all the things. And oh, politician, oh, please like the way that I do it because my way's better and all these things. And then I read this book and I went, woo, maybe I need to step back. Maybe I need to just shut my mouth. Maybe I need to be a little bit humble over the pride and maybe show some curiosity over conviction and see what all this is about. And then I think we all have seen this quote from Ted Lasso, be curious, don't be judgmental. And so, that's the beauty of these online webinars is that there's no judgment here. We all want to learn this thing. We all want to provide better care. We all want to use technology the way that technology is supposed to be used. And so if you're questioning it, don't, because you're going to find support wherever you are. And so that's kind of how I went. And now in my practice, it's a big part of how I treat patients. We're still kind of redoing our website, and I have newer pictures. Don't go to my website. It still shows the baby Derek. Now this is more the seasoned Derek with the gentle wave. But I throw this in there from Jordan Peterson is that you have to kind of understand your protection as a human or as a species. Zebras have stripes because they don't want to stand out because they don't want the lion to come get them. The fish, you don't want to be the outside of the school because then you're bait. You want to be on the inside. So, you know, taking a leap and knowing that you're going to do something different is going to get you some strife one way or the other, good or bad. And so I share this next slide because the day I kind of came out with my LSU people and friends and group chat, we all have our group chats that hey, what do you think about this case? And so all my buddies at LSU, I came out and I'm going to do the gentle wave and I'm just going to share kind of the thread to you. Ritter, in Tulsa, gave me a hard time, but believe me if I'm wrong, but this is Dr. Clorox that we're talking about. That's kind of the nickname I was given. Bleach or nothing is kind of what I went by. And then Lally, who's now in New Orleans, was like, never go full gentle wave. Of course, we all know Tropic Thunder and everybody else kind of back. I definitely went full gentle wave. Like I jumped off and of course, my good friend Mark came to kind of my aid too and, said, hey, Pete definitely goes 100% about everything, but man, I got shredded by my friends for a while about, trying something new and I'm still doing it. And so, just all to say is that you're going to get some pros, you're going to get some cons, nothing against any of my friends. They're still my friends and they still are, asking me questions about the gentle wave. We don't hate each other. We're not upset with anybody, but you're going to get razzed a little bit. And I think it's great. It's great to kind of get, iron sharpens iron. You're going to know what you need to know. But, um, you know, like anything with life, you're gonna get some heat one way or the other. So I also put this on there. It's impossible for a man to learn what he thinks he already knows. And so just that was kind of a long-winded way to get to how I use GentleWave, and these last couple sections go pretty quick. But don't be afraid to learn something new. So basically, how do I decide between GentleWave versus non-GentleWave? It's pretty much two things I look at. It's the patient and it's the tooth. And these are kind of how I go down it. Is the patient on time? Have they done all their paperwork? Referrals, question. It's the time adage. It's 2:59. Your 3 o'clock patient's getting ready to show up for the last patient of the day. They walk in at 3:01. They don't have any of their paperwork done. They have a million questions. They didn't put their med history in there. They're giving you a hard time about the CBCT. They don't sit down in your chair till like 3:30, and then you got to get them numb. And maybe there's somebody you got somewhere you got to be at 4:15 or all these things. And they didn't respect your time. And so a lot of those cases, I go, you know what? I'm going to do a traditional root canal. I may not have time to run the gentle wave because that just is what it is. Versus, the other patient that's 15 minutes early, has all their paperwork done. They're in your chair at the top of the hour, and you got a whole hour to do whatever you need to do. And I think a lot of us in here, we can do a root canal in about an hour. And I think the GentleWave doesn't add any time. In fact, on the cases I'm going to show, I put the times on how long it took me, and my times are from rubber dam on to rubber dam off. Um, so there is a patient response, and then there's also you gotta look at the tooth. Is restorability, number of teeth, surfaces, perio, all these things. I write these things down there because my practice isn't necessarily probably the typical endodontic practice, meaning I take every insurance, including Medicaid. And so some of my patients drive 2 or 3 or 4 hours, spend the night in a hotel and see me the next day, and they maybe only see me once, and they maybe only see me for an hour. And I can't just do a consult and answer all their questions and have them spend another 8 hours in a car. So I'm really motivated to meet and treat in the same day. And so I put this up there to say that, if you take insurances, you do everything, you can negotiate your contracts, and you need to know your contracts. And I've done a pretty good job with that. And that kind of leads into my second thing is growing up in endo. My dad always helped everybody. I got into OU dental school, and everybody there was like, "Oh man, your dad was great. He took all the insurance. He never turned a patient away. If anybody needed a root canal or they couldn't pay, your dad always did it and took care of them." And even here in Iowa, I'll still get people, "Oh yeah, your dad helped my mom, 10 years ago, and the tooth's still there." And so my focus was, not only do I want to do root canals, I want to do root canals for anybody and everybody. And so I try to take every insurance I can and practice how you want. So you can choose. You can practice exactly how you want to do it. And I try not to limit my days. Some days it's 4 to 6, and some days it's 12 to 14. And so I just try to say, do what you can. There's no standard out there for you guys out there where you have to do 10 a day, or you have to do 5 a day, or if you only do 2, it's like a bad day. It's a roller coaster. There's going to be great weeks and slow weeks, but by and large, talking to my dad for 45 years, it all comes out in the wash. So don't get too up or too down, is kind of what my dad would say. Just know that, well, you got patients on the schedule tomorrow, so get to it then. So a little bit of yes and no. Why is, this is definitely a yes. This one is definitely a no. This one is a yes just because the patient was on time. It's one of my A referrals. They removed all the decay. The patient understands the goal. It's a good prognosis. They've removed all the decay. They basically placed a great temporary. Perio's awesome because they've had their teeth cleaned. We know endo works because the root canal's healed here. So yeah, slam dunk. All I have to do is access this IRM with my number 8 round, hook the GentleWave up, and I'm good. Versus this one who, the general dentist failed to diagnose 12 and 13. I'm kind of big on, yeah, this tooth hurts, but if these teeth are also hurting too, you want to fix everybody's problem. And if you can fix everybody's problem, fix it. The perio wasn't the best. This patient all had glued their own gems on their front teeth. So there's kind of a lot going on. And so just you look at them, I don't see anything wrong with this GentleWave case, but again, I don't see anything wrong with this case either. I think we solved the patient's concern. We removed the tissue that was causing them discomfort. We restored the teeth for the patient. Yeah, they may not be GentleWave clean, but I think the traditional root canal is going to work just fine. There's just an example there. Retreatments are an obvious yes for me, especially if they're silver point. I've got a lot of single appointment silver point retreatments that are doing great. So anytime I see a silver point, it's automatic. And then you got other anteriors that look like this. This is going to be some time in your chair if you're going to restore all those, be able to get the GentleWave on every one of them and all those things. And so this patient was also a very important patient. It was also my father-in-law. So got to do it then. Got to bring out all the bells and whistles for that one. And this one was, I think we can all look at that and kind of conceptually make the decision that, that's going to be some time suck to be able to run the GentleWave on all those. And, you look at both of them, and I think they both still look like great root canals. we meet the need of the patient, but one was GentleWave and one wasn't. Um, Got a couple more. This is a yes, history of a cracked tooth, no decay, good perio. There's a lesion here. Um, Versus we can all look at this and go, "Oh, that's a kid." Peak, you run GentleWave on kids. I would, if I could wave a magic wand, I would always use GentleWave on every pedo patient. But we all know out there that's really not going to happen because there's patient management, or they don't basically want to sit still for that long, and so you look at this one, and she asked all of her questions. There's a history of a crack. She pretty much requested the GentleWave. She'd gone to our website and she'd done her own research and pretty much told me what she wanted. I was like, absolutely, we can do that for sure. And then the other one was, kids. Sometimes you can, sometimes you can't. I would opt to put the GentleWave on every pedo patient if I could, um, just because it just cleans all the nooks and crannies that much better. Again, able to make a small access to get all these maybe a little wide on this mesial aspect here, but a good GentleWave case and a good non-GentleWave case. I think I got one more for my yes no. And For yes on this one, there's no decay. And anytime I have a patient that has an acute apical abscess, swelling, it's like, God, I want to put the GentleWave on it so bad because I want to suck everything out. I want to make sure I'm cleaned all the way down. Anytime I can see the canals all the way down, I'm like, oh man, I'm not probably going to have to instrument this one or do minimal instrumentation or instrumentation and do non-instrumentation endodontics, which is kind of where I'm kind of trending a little bit. And then this one, I think we can all look at that and kind of go, yeah, that's going to be a perio nightmare. It's going to bleed like hell, and it's going to be kind of tough to get a seal. Not that you can't do it, but that's just the reality of the situation. Where you look at these two, and this one, I think I love GentleWave on mandibular molars. I think it's fantastic just to see the sealer rip through the isthmus between the two. And then, this one was time and restorability and all the things. And you look at these two, and I think they both look good, but this is what I want. Very minimal access here, minimal instrumentation here. Got a little bit of sealer out the side on the back. Again, nothing wrong here. Was able to get a good margin, clean all the way down to the apex. But when you kind of take the off angle, that's kind of really where the GentleWave shines, is because you can't really isolate the two canals because the sealers just run between both of them. And so, I really love the GentleWave on mandibular molars. So that's kind of a short way of how I kind of choose back and forth. And so in talking with Wendy, she really kind of thought, everybody here kind of wants to know how I do things. And so again, I'm big on perspective. What does 2 million mean? GentleWave's almost to 2 million. What do the numbers mean? Probably I'm only going to do about 40,000 cases in my career. So after, 10 years, I've got 16,000. I probably got another 15, 20 years left. So that's probably going to be a little over 40,000, but we're just going to round numbers here. If you divided that by 2 million, that's 50 times more than what I'm ever going to see in my career. So I think you need to realize how big of a number 2 million is. Because for all of us here, that'd be like, I think there's like 70 of us or 50 of us on there. That'd be like all of us on this call. We got all of our cases for our entire career and smushed them together. And that's the data that this 2 million gets us. So it's an astronomical number in our world. And I think it's a very good thing to see that we're approaching that number because it just solidifies how good this treatment is and how well it's cleaning teeth. And so I don't want to get into, oh, here's my pretty case. Oh, look at the healing. Here's my pretty case. I just quickly want to go through, yes, we all have cases with minimal instrumentation. We know it heals. Yes, we have initial cases that we don't do any instrumentation and we see them back in 3 months and the lesion's gone. Yes, we have retreatments where we thought the tooth was hopeless And we ran the gentle wave, and holy cow, I can't believe that cortical bone came back on the buccal within 12 months. Yes, we have anterior or teeth that, man, there's no way I got to file all the way down to the end, but somehow the sealer got down to the apex because of gentle wave, and that lesion's gone. We have anteriors, big open apices, big lesions up into the nasal sinus. Do we run gentle wave on that? Absolutely, we do. And we put in, I used endosequence root repair material here. And a year later, that lesion's gone. Retreatments, big lesions, run the gentle wave on both teeth, lesions gone. So the point of that is just all the cases I'm going to show after that, I may not have a recall. I may not have a 3 month. I may not have a 1 year, but I follow all of my cases pretty regimentedly just to make sure things are healing. And I think we can all look at it and go, it works. It heals. Big, small, big canal, small canal, big lesion, small lesion, open apex, closed apex, gentle wave. It's going to cause things to heal. But I really wanted to focus on what's my protocol to kind of maybe help some of those out there kind of realize, all right, how do I be efficient? How do I get my cases closer to 30 minutes? How do I get my cases under 40 minutes? How do I do what I do? And this is kind of how I do what I do. Every case gets a CBCT. While the patient's in the chair and I'm listening to the symptoms and listening to the questions, I'm measuring it in my office. So I'm estimating my working lengths. I'm confirming the diagnosis. And then we get the patient numb. I do complete caries removal. Obviously, you make your pre-op diagnosis, and I think we all need to look in the canal and go, yep, we got it right. No, we got it wrong. Do I need to change my diagnosis? I irrigate with sodium hypochlorite. And then the first file I pick up is a number 2, short number 10, or depending, 25 millimeter number 10 to go to my estimated working length, just to kind of feel it out with my hands, just to make sure nothing's crazy before I start spinning files down in the canal. And so the first file I use is the ZR1 by Slim Shaper. I rinse dry. I actually get working length with a 15 millimeter hand file, or not a 15, number 15 hand file. And then I go through my instrumentation protocol, whatever the tooth calls for. If I want to go to a 35, if I don't want to instrument, if the canals are bigger and I'm trying to see what gutta percicona I'm going to use, all the little question marks, and then I run gentle wave. I don't do a gutta percicone fit, but I felt like it was just of me to put this on there for those of us doing board certification. Pick one of these two because you got to justify your length. And then once I've run the gentle wave and I've got the cone that I want to work, I just put sealer in there and I seal it off at the orifice and I'm done. You know, if you do a core, you do a core, you do your final radiograph, you do your final radiograph, and that's it. So it's pretty much access, do a little bit of instrumenting, run the gentle wave, fill it up. I pretty much tell people I just got to find them, clean them, and fill them. That's really the 3 things that we have to do. And so these are the Slim Shapers that I use. I like to go, I've been liking the 35 lately. I use BC Ion with this flexi tip, and I try to get that all the way down as far as I can. I don't push, I fill it in there, and then I maybe give the cone 1 or 2 pumps, and then I seal it off at the orifice, and that's it. So I got 5 minutes left. I got some recent cases. We'll just run through them, and then we got questions. So, number 30, PN or pulp necrosis, symptomatic apical periodontitis. We fill everything into TDO. I have my CBCT up in my office. I look at the sagittal slice of both sides. With CareStream, you can kind of go through the canal and it can spit off, a pretty dedicated length if you want it to your working lengths. In this case, I would just 19. I want to make sure I can free and clear to 19. And then if I need to adjust with my actual working length, I can. I visualized. I know I got 2 in the back, 2 in the front. Execute. That's all you got to do. In this one, you get all these deltas in the apex of the distal canal that you maybe didn't know that were there. And I think this brings up a good talking point. Peak, hey, why'd you get a sealer puff on the distal and no sealer puff on the mesial? What'd you do different? I have no idea. I think it's just sometimes the case. Sometimes you get a puff, sometimes you don't get a puff. And, I wouldn't live or die on whether you do or whether you don't. It's just sometimes that's just how it goes. I don't know that there's a exact science to it. And in this case, start to finish took me 31, just over 31 minutes from rubber dam on to rubber dam off. Um, Retreatment, previously treated, um, symptomatic apical periodontitis. I think all of you can look at this and go, that mesial looks funny. You were right. So we put everything into TDO. Yep, we got a missed mesiolingual. We got to work our way down that one. Probably a little bit wider of a distal than what this shows, so maybe have to do some work there. This is kind of a quicker way I would do it on CareStream is just draw a straight line just to give me an estimated working length. So I got an idea. This is 19. So if I'm putting something down the mesiolingual and it's going to 15, I know I got a problem. That's just kind of all I use it for. These are the retreatment files I use. I just use the 1 and 2. That's just to get the coronal portion of the gutta percha out. I've been fortunate that sometimes you get that out and everything just comes out because there isn't any sealer in there. And then you retreat the case. These are to a 35. I think that's a yellow, so a 50 in the distal. Again, 2 sealer puffs this time. 44 minutes. That's pretty good time. 40, 45 minutes for a retreat for me is probably pretty par for the course. Um, do I use it on anteriors? Absolutely. Anytime I see an anterior and I see a radiolucency on the mesial side, I know I want to use the gentle wave on it for sure. We look at everything. Oh, let me go back. Little teaser there. You know, Straight shot, 23 millimeters. Got a little sealer puff out there. Yeah, that makes me feel good. Great case for the gentle wave there. Anterior retreat, 30 minutes, 33 minutes. Pretty straightforward case there. This is, I think I probably made some of you nervous out there when you saw this come up. You're like, whoa, Peak, you got gutta percha, likely into the sinus, chronic apical abscess, this big old post. This is kind of like a myriad of how do you manage all these things? Previously treated chronic apical abscess, put everything in TDO. We get our sagittal slice, and oh, this is a contraindication. You got, there's something. All of this tissue in the maxillary sinus is a pretty big backstop for me to be able to run the gentle wave on this case. And so pre-op, post-op, again, just under 45 minutes. This is obviously I obturated the sinus tract that's coming out, but I'm pretty happy with that, and the patient's pretty ecstatic too when they see the pre-op and post-op, and that you were lucky enough to get all that out. That's definitely one for the books, I think. One more here. Anytime I see these kind of come off at a pretty sharp angle at the end of the chamber, I know I have to be pretty minimalistic and not use big files. So we're measuring those, kind of getting an idea how long they are. Pretty abrupt angle coming off the chamber, and got this little other canal that I don't know that I would have been able to get in there, but very minimal, very small access, very small prep. You can do that with the gentle wave, and this was just under 40 minutes, just over 35 minutes. So some tips and tricks. When I do a maxillary tooth, I put the gentle wave on my side. When I do a mandibular tooth, it's on the assistant side, and we just find that it rests on the tooth, and all we really have to do is put our foot on the rheostat and sit there for 9 minutes. So a pretty good break. If you look at your op, again, maxillary, put it back here, mandibular, put it there. It rests on the tooth a little bit better. The obturation material that the practitioner should use should be the one that works best in their hands. And so what I always say is BC Sealer has just been the paintbrush that's always worked best in my hands. I tried AH Plus, I've tried them all, and
Sure.
for me, I just think it's my paintbrush, and so use all the other paintbrushes and find the paintbrush that works best for you and best for your cases. I think any of the newer sealers are going to do and have the properties that they're supposed to have, but maybe it just works better for you than somebody else. And so
Sure.
always try something new, and that's my 2 cents there.
Are you using high flow or regular?
I'm using the new BC Ion.
Okay,
So the ion is kind of a mix between the two. It's
sure.
the best way to explain it, I think. And I haven't had any issues with it. I still seem to enjoy it. There's been no need to try to go to look somewhere else other than just being inquisitive and somebody else asked me, "Hey Pete, can you look at this and tell me what you think?" Yeah, I'll look at it and tell you what I think. And I still just keep going back to BC because it just happens to be the paintbrush that works best in my hands. I don't know any
Great.
other way to say it other than that. And growing up in the industry and growing up around my dad and seeing how my office looks compared to his first office, things change and it's going to change fast. And I think you got to be ready for it. And I think the Gentle Wave is the start of it. And so I definitely wanted to be one of the early adopters. I'm not. I'm kind of middle of the pack, but it's just it's just great. It's just so much cleaner on the inside. It's so much better for the patient. It's so much less stress for the practitioner. I think it's less stress for the patient. That's one thing we didn't really spend time talking about is you hardly ever hear anything of post-op sensitivity like that number 9 retreatment of the silver point. That was my father-in-law. I mean, if I don't do that right, I'm going to hear about it. And he texted me that night. I feel great. Next morning, no issues. That tenderness I had completely gone. Whatever you had sucked everything out. I was like, yeah, I did. Well, of course I did. I wanted it to. So, um, when you get to work on people, you really get a better feedback of what it is. And I've had the pleasure of working on some close friends and family members, and they're all pro GenoWave and they're all working great. And so, it's not just that, it's other patients, but do I want to use it on everybody? Yes. And I think I need to say that. If I could choose and wave a magic wand, could I hopefully build time to be able to use it on everybody? Yes, I would love to. But
Yeah,
sadly, that's not reality. And I think everybody on this needs to understand that. I don't think there's anything wrong with the traditional root canal, but I think there's definitely something better about a GenoWave root canal.
great. So I'd like to take this time and have Q&A. We have some things to talk about after your presentation. So
Okay.
if anyone wants to, you don't have to come off camera. You're welcome to, but please come off mute and really ask Dr. Peak anything.
The QR code is all my contact information. So if you want my contact information, that's my email, that's my cell phone, it's my website, Instagram, all this stuff. Seriously, call or text me anytime. Like, I'll talk root canals forever. I mean, it's what my dad and I do all the time. My mom and my wife give us a hard time. She's like, "Do you guys ever stop talking about root canals?" So it's either the business side or actually, oh, you should see this case or all those things. So I guess I'm nerdy about that stuff. So if you want to share cases, blow my phone up. I'll send some cases back. If you got questions, I'd be happy to be a resource or somebody to talk to about cases too.
Thank you. That's it. That could be the tip of the whole webinar tonight. We all have questions for longtime users. It's
Oh
just
yeah,
simple clamp questions. What did you do
yeah.
in this case? So thank you for offering that. Maybe there's one last question. Do you have an opinion on any certain apex locator that you like?
Well, good question. I've used the same one
Same here.
since residency.
Same here.
I have 4 of them. I use the Root ZX Mini,
Yeah.
and I think you do have to spend the time of knowing the settings of your apex locator. What bar is what you want it to be radiographically. So I think I spent that time, this was like 10 years ago. I mean, it's like the one thing that I tell them, do not drop this. And they don't drop it because you want to calibrate it. And to calibrate it, you really need to spin a couple cases to know where the sound or where the reading is, and then set it and forget it. And so I would just say any apex locator that you spend the time to know and read the book about and put the time into getting the setting the way that you want, I think any one of them is going to be just fine. But I've had the Root ZX Mini, And my dad just had these two fingers. These were his apex locators. So maybe I can make these my apex locator someday, but still I'm confined to these and the Root ZX Mini.
Great, thank you. So when you use your Apex locator, last question, do you try and get patency?
The way I understand how the apex locators work. So we have, this is how I show the patients. We all have like the minor and major constriction. The way that the apex locator reads is it reads from out to in. So I know how my apex locator goes in is I'm getting the beep and then I want to get a solid beep to maybe I'm going from the minor constriction to the major constriction. So it's getting that out and then I'm rotating it back to the setting that I have on mine. So um, ideally, I like to get patency because then I know when I obturate that I'm obturating to the terminus of the root canal system. But there are some cases I showed where I never got patency. I didn't even sniff the apex. And in some of those, I went, well, my only option is to run the gentle wave and see if I can't get sealer to go down there. And before I had the gentle wave, it would have just been extraction, let it go. Now I've done so many of those cases now where if I don't get paid, see, I'm like, okay, well, I know what my pre-op would have been like pre-op on the CBCT. If it was like 20 and I get to 18, I'm like, okay, we can do that. Well, maybe we get some sealer. There's something weird out there. So I think more and more I roll the dice on those cases where I can't get patency. Ideally, yes. If I can't, Genowave and do a lot of this, and hopefully I get sealer out of the end of the tooth, and then just watch it and tell the patient, be honest with them, go, hey, this isn't how I normally would do it, but we're going to watch it. We'll see you back at 3 months and 6 months and see how you're doing. If you got any issues, call us.
Again, thank you, everybody. We're going to end 5 minutes early, which is always everybody the best lecture I've ever been to. So we end a little bit early. So thank you, Dr. Peak. Your story is just infectious, and we're glad that you're here. Everybody go have a wonderful night, and we'll see you again in the third Wednesday of January.